Before we start today's episode, I want to start with a trigger warning because we're going to be talking about pregnancy loss and miscarriage today. I want to acknowledge that this is a sensitive topic. It may bring up strong emotions for some listeners. If at any point you feel the need to pause or take a break, please do so.
These are all just really important messages because it's so complex. And I think as human beings, we like to put things in little categories and be like, well, if this loss is in this kind of way, it means this, as opposed to depending on who you are, loss means different things to different people at different stages in time, right? Somebody could have a miscarriage in her early 20s and feel relief. And somebody could have a miscarriage in her 30s and feel complete devastation. Could have a miscarriage in her 20s and not even think of it as a baby. And she could have a miscarriage in her 30s and have already imagined names, right? We are complex humans. Our grief is complex and loss is complex.
Welcome to my fertility podcast, Superhumans,
a space for honest conversations, expert insights, and stories of resilience.
Whether you're just getting started on your fertility journey, facing challenges, or looking to educate yourself, you are in the right place.
We are Dr. Mavis Garcia
and Dr. Wise,
fertility specialists at Markham Fertility Center located in Markham, Ontario, Canada.
Think of us as your biggest cheerleaders. Let's demystify the world of fertility together.
Welcome to another episode of My Fertility Podcast. We have with us today Dara Roth Edney. Dara was with us previously on episode 57. She talked about navigating Mother's Day, and her episode was so well received that we had to have her back. Dara is a registered social worker and psychotherapist with over 20 years of experience and the founder and clinical director of Informed Fertility, a group counseling practice specializing in family building. Dara supports people navigating infertility, pregnancy, and infant loss, as well as members of the 2S LGBTQ+ community and solo parenting and family building. She provides grief and relationship counseling, third-party reproduction counseling, and practical tools for coping, communication, and boundary setting. Dara developed and teaches Canada's first university-level professional development course in fertility counseling. Is the past chair of the Counselling Special Interest Group of the Canadian Fertility and Andrology Society, a board member of Donor Conception Canada, and a recognized leader in the field of reproductive mental health. Her work is grounded in inclusive, trauma-informed, and evidence-based care, shaped by her clinical expertise and her personal life experience with infertility, pregnancy loss, and surrogacy.
Welcome back, Dara. We are so excited to have you on today's episode. And I know we said that a lot. However, our previous episode that we did together about navigating Mother's Day was an incredible conversation where we spanned, talking about Mother's Day and infertility, talking about grief. And I think everybody walked away with incredible life lessons from that episode. And so we're just so excited to hear what is going to come out of today's conversation. For anyone who has not listened to that episode, I highly, highly recommend it. I know I sent it to everybody that I know because there were such great tidbits in there for everyone. Today's episode, we're going to be focusing on the emotional journey of miscarriage. So, although we know you very well, for those people who are listening to this episode for the first time, can you tell us about yourself, your work, your background, and why you do what you do?
Absolutely. So thank you. Thank you for having me, and thank you for having me back. It's so incredible to have this kind of platform to talk to people about things that are so important and so often not talked about. In terms of my background, I'm a social worker and a psychotherapist. And initially, actually, I was working with geriatrics. I really enjoy working with the elderly. I was working in palliative care and women's mental health in long-term care and nursing home. And I started going through my own experience of infertility. And old people really like babies. And they asked me all the time when I was having children, and a lot of the people that I was working with, a lot of the residents and patients had dementia, and they would forget what I told them. And so I was constantly, it felt at one point that all day long, all I was doing was telling people that I didn't have children. And so I actually had to leave that job. And I know a lot of people that I speak to right now as a clinician really struggle with that balance with work. And so I definitely had that experience myself. And then I segued into doing research in women's mental health as my own infertility continued. Ultimately, I, over the course of about 6 years, went through 6 cycles of IVF, a number of surgeries. I was diagnosed with endometriosis at one point. We tried a variety of different things. And ultimately, it became clear that I would not be able to carry a baby. I did have one early pregnancy loss, but mostly I wasn't getting pregnant. And then eventually I had my children through surrogacy. And so I have 2 children, each carried by a different and amazing surrogate, actually on either side of the Canadian law about surrogacy. They were born each sort of buffering that law. And during those years, I was focused on building my family, of course, and all of that, the interruptions that come in terms of your personal life and your work life. And I'm fairly open with my own personal experience, although, and I'm sure we'll talk about some of that, there were definitely boundaries and times where I pulled back and I wasn't as open. But I think because of my typically open nature, people were approaching me and asking me and talking to me about their own infertility and about their fears about IVF. And so as I moved through my own journey, not while I was in it, because I think while you're in it, it can be complicated to counsel people when you're in the midst of that pain yourself. But as I moved through it, I started counseling people in that area. And so now it's been almost 25 years actually since I've been working in the field of infertility in some way or another, and more than 20 years since I've been doing this full time. And I have a group practice now that's entirely in the area of fertility and reproduction, working with people who are struggling with miscarriage, with infertility, people who are accessing fertility treatment because they're single or queer, or all the different reasons people do this. And so that's my personal sort of passion project, I would say, that I've been really lucky enough to make into my career in this way.
Thank you for sharing that. I have a question and a comment. I'll never forget, I had a patient once who I actually became very close with throughout her journey. And she had multiple miscarriages, and then she needed IVF, and eventually they conceived after multiple embryo transfers and a series of treatments, including surgery. And as she was pregnant, we had some conversations like I like to do with my patients. And she said to me, I love your content, Dr. Garcia. You talk so much about infertility and whatnot, but every time that you talk about infertility, has your patient with recurrent miscarriages, I don't see myself in that word infertility, which kind of took me by surprise, to be honest, because from the fertility specialist point of view, it's a very similar context. What we want to do is get patients to have the baby in arms, whether it is because they cannot conceive in the first place or they're conceiving and not being able to carry to term. So when she said that, I was like, wow, I really need to start thinking about the language that we use for infertility and make sure that people with recurrent miscarriages are being seen in that language as well. So can you comment on that and how we can talk about that experience in a way that people with recurrent miscarriages are seen as well, as much as when we talk about infertility in general?
Absolutely. And I hear that all the time. I think it's so wrapped up in the different things that people feel ashamed of, actually, ultimately. There's the people who are struggling to get pregnant and the feelings of sadness and grief and shame that comes with not being able to have that happen and not know, depending on where you are in your journey, is that about not being able to conceive? Is it about no implantation? Like what's happening? Versus when people are getting pregnant and there's this idea that it really is conception, that infertility is about an inability to conceive. So that if the issue that you're having is recurrent pregnancy loss, then you have no trouble conceiving. And in fact, that is often in a terrible way, kind of, for lack of a better way of saying it, thrown back in people's faces, where people say to them, at least you can get pregnant. Right. I've had people say to me so many times, like, what does that matter? How is that helpful to keep getting pregnant and not be able to bring that baby home? I think for some people that differentiation allows them certainly to maintain some hope, like that, in fact, if they get that right egg, if they get that right sperm, that because they can conceive, maybe they will one day be able to carry. But I also think it's a way of identifying separately, right? The same way in many aspects of our lives, we want to be seen for who we are, for our experience. And somebody who experience is not infertility, it doesn't mean that their experience is worse or easier. It just means it's different. It is a very different experience to never see a positive pregnancy test than it is to constantly see a positive pregnancy test and constantly have that end in physical pain and emotional trauma. And I also want to just highlight, and I'm sure we'll get to this too, that obviously some people have both, right? I speak to lots of people who they have a number of miscarriages and then they don't get pregnant for a period of time. And it ends up being a combination of infertility and recurrent loss. And of course, you don't have to have multiple miscarriages for a miscarriage to be devastating. Some people have one, and so they don't fall into that recurrent pregnancy loss category. But that doesn't make it not terrible and devastating and heartbreaking and frightening.
Absolutely. I think that's such a great point that we probably in a fertility clinic, we're seeing the majority of patients with infertility, but that portion of patients that we do see with recurrent pregnancy loss often don't see themselves even in the title of like infertility clinic or fertility clinic. They're like, well, I'm fertile. They'll say something along those lines sometimes. And so, trying to kind of be mindful of that, I think about that. And then trying to make them feel included, basically, right, is a really big, important thing. And that kind of speaks to a broader topic, I guess, around miscarriage in general. I know in the last episode, we talked about grief and we talked about loss, but miscarriage in society, I would say, is viewed a little bit differently. And many people sort of refer to it as like an invisible loss. There still seems to be a lot of silence, taboo around it. Why do you think that is? How do we start to shift that?
Mm-hmm. Great question. Interestingly enough, your question links to a comment I was going to follow up with that came to me as you started asking this question, which is the comment that you made that it's important to shift how we talk about it because it'll help people feel included. And that's true, but I think it's more than that. Language is important and language leads to decisions. So if all we're talking about is infertility and we think of that as the inability to conceive, then where are we putting advocacy campaigns? Where are we putting research money? How are we actually offering services and treatment to people? When I look at what happens when people have miscarriages and the lack of information they're given, the way they're treated in hospital, how long they have to wait for a D&C, like all of those kinds of things that happen that I think if we talked about it more, it's not just about belonging and being included, right? It's actually, it brings it to the forefront in a way that much more important and present for us to actually deal with and then make maybe policy changes or, more information being put forward, more discussion about it. And so when I think about that second question, the invisibleness of it and the fact that it sort of is that the further along a loss happens, that somehow in the world of the people around us, the more legitimate it is, right? That somebody, for example, who has a stillbirth, that is not invisible. Somebody who has a loss at 25 weeks, that is not invisible. Somebody who has a loss where it's a biochemical pregnancy before heartbeat, it's not even called a miscarriage by many people. Somebody who has an ectopic pregnancy, it may not be considered a miscarriage by many people. Those are losses that aren't so obvious, and yet the pain is so deep and the fear is so deep and the trauma can be really, really deep as well. So ultimately, I think being able to look at all of these things and say, how are we talking about these things? And what are the differentiations we're making with loss? The Pregnancy and Infant Loss Network, which is a support network out of one of the Toronto hospitals, I heard that they actually changed their definition of miscarriage to include biochemical pregnancies, ectopic, and embryo losses. Not to suggest that they're all the same or that the emotions or the consequences of each are the same, but to recognize that if you're the patient, if you're the person, if you're the couple that are going through this, then those are losses. And you feel those losses.
I think it was really interesting what you said there, that now that they're incorporating more things into the definition of pregnancy loss, and it legitimizes, might be the word, patients who are experiencing a biochemical loss in an ectopic pregnancy, because those are often forgotten, often, not quote unquote counted. Many people feel like they're not significant enough. And so it's very, very interesting.
Yeah, I agree. I've had people say to me, like, the clinic keeps calling it a chemical pregnancy. Does that mean I didn't have a miscarriage? Because it feels like a miscarriage. Like, is that not what this is? And they're not saying it from a medical perspective to try and understand the science. They're asking me because they're feeling like they're not allowed to feel the way they feel, that they shouldn't have the grief because they didn't have a traumatic bleed. They didn't need a D&C. Like, they feel like they don't have the right to have grief. And I think that's where we can look at what is the difference between even like a political ideology versus a personal response, right? So I don't mind sharing that I don't believe life begins at conception. That's not my belief system. On the other hand, when embryos didn't attach, it was devastating. When I had to think about what to do with an embryo that we were unable to use, it was heartbreaking. The fact that I don't feel like that's a baby doesn't change the fact that all of my hopes and dreams are wrapped up in it. And of course, for some people, that is their value system, and they do believe that it is a baby. And so whether it's a biochemical pregnancy, an ectopic pregnancy, a later loss, all of that is a loss of a human being. Or for other people like me, it's the loss of hopes and dreams. For a lot of people, a significant amount of money. Right. And I find sometimes people get confused by that, where they feel like, why am I so upset? I don't believe that that was a baby. Right. Like somebody who doesn't believe that life begins at conception can feel like it was just 5 weeks. It was just this. It was just that. I think ultimately that goes back to delegitimizing how women feel, ignoring how men feel, and not looking at the depth of emotion that goes into all of this, which is just immense. And people's experiences matter, and they matter from the beginning. They don't only matter later on.
Another group that I'd love to mention at this point is also the patients who opted to terminate pregnancies due to anomalies, where it's not a miscarriage per se. I think it's very challenging for that group because it's a pregnancy termination. They decided, and for those of you who are listening to the podcast, I've got air quotes going like crazy over here. Whereas it's not classified as a miscarriage, it's not a miscarriage. But that loss also carries a lot of emotional weight on top of other emotions, potentially of shame and potentially of now fear of weird political repercussion in certain areas of the world right now. I just wanted to mention that one for anyone who has experienced that, who might be listening to the podcast, that like that's another big group as well.
Absolutely. So termination for medical reasons. I mean, there's a reason we have another term for it as opposed to termination or abortion just on its own, which I believe are also very legitimate reproductive choices. There is something obviously unique about termination for medical reasons because these are very, very much wanted babies. My understanding is that most terminations for medical reasons that happen later in a pregnancy are for these very, very, very serious medical reasons. And so there's a category of people where, of course, it's a choice. It's always a choice, but where that choice is much more clear because there wouldn't actually be a baby to bring home. And other times it's not quite as clear, and that there are conditions where it's not clear until a baby is here how devastating and catastrophic it would be. And people are making the choices that they believe are not only best for them, but best for their babies. And oftentimes what I say to people when they are filled with some of those emotions that you described, grief and shame and confusion, that we have this small period of time where we can protect our babies. And in utero, making a decision to end a pregnancy because all of the evidence suggests that that little human will be born with catastrophic, painful, potentially life-altering or life-ending issues is for many, many people the best way that they can show love to their baby. And that's a completely appropriate choice, and one that is made even more devastating by the political noise around abortion and the assumptions that are made about people, and in particular women.
Yeah, absolutely. And we're not going to turn this into an abortion debate, but at the same note that Dr. White was mentioning that group, yeah, people who even have abortions in the first trimester because they just can't manage being parents at the time that they're pregnant. I have seen patients that then come later for infertility, and the amount of shame that they have that, I had an abortion 10 years ago, 5 years ago, this many years ago, and now I'm here really wanting to have a baby. And they told me right up, it's this punishment. Am I being punished for what I did? And I think that basically it's not to compare or anything, but at the end of the day, the experience of being pregnant and no longer being pregnant, it's very complex and very unique for each individual. And, whether it happened at the embryo loss stage or a first beta ECG level or the 6 weeks or 8 weeks or a medical termination or a termination because you just couldn't support a pregnancy at this point, there is still a degree of loss, shame, and silence that comes with that, which of course is going to be unique and different for everyone.
And can I just say, if you've had a previous pregnancy termination, that is not the cause of your
Yes.
infertility.
Mm-hmm.
I know that's not what this podcast is about, but I hear that all the
Mhm.
time, and I want to shout it from the rooftops. That's not your medical reason for your infertility. And then it's not, karma or payback or whatever that's given you, quote unquote, infertility at this point. So I want to just put that out there.
These are all just really important messages because loss it's so complex. And I think as human beings, we like to put things in little categories and be like, well, if this loss is in this kind of way, it means this, as opposed to depending on who you are, loss means different things to different people at different stages in time, right? Somebody could have a miscarriage in her early 20s and feel relief. And somebody could have a miscarriage in her 30s and feel complete devastation. Could have a miscarriage in her 20s and not even think of it as a baby. And she could have a miscarriage in her 30s and have already imagined names, right? We are complex humans. Our grief is complex and loss is complex.
Dara, I have been practicing for about 25 years. And before I was in the field of obstetrics and gynecology, especially in fertility, I made different rotations for different systems and different hospitals. And I've heard a lot of different comments about miscarriages that I don't hear now simply because of the work that I do and the people that I work with. But I am sure because I talk to patients outside of my little bubble of the fertility clinic that tell me that this kind of language is still being used out there. And this would be things like, it probably wasn't a healthy baby, so it's a good thing that this happened. Or you mentioned at least you know that you can get pregnant, or you should be able to get pregnant your next period. As soon as you get your period next, you could start trying again. It was really early, so that's good that this happened early, but better than it happens later on. Or things like, I specifically remember a time when the person I was working with, I was a medical student, made a comment about this patient being dramatic about her miscarriage. And it was early on, and there was really no need to be that dramatic. Can we talk a bit about that? Talk about that language. Obviously, I know that as physicians, we can always do better. But can you talk about what that does to people and why that language is so, so harmful to the patient experience?
Absolutely. Ironically, even the word miscarriage that you've somehow carried mistakenly, even the word itself, I find to be quite loaded. Or when you think about the way people talk about, oh, she lost the pregnancy, right? Even the language we use around it without thinking about it, because I don't think there is other language right now, it is very blaming and shaming. There's, of course, an assumption that fertility is always based on the female body. And even when people are acknowledging now the role of sperm, the assumption is that the role of sperm ends as soon as the embryo is created, without an acknowledgement of the impact of sperm on placenta, on fetal health, on any of those kinds of things. And so people who are pregnant are interpreting that themselves and internalizing that themselves. And there's no reflection in our society of the normalization of first trimester losses with the pain of it, right? Even though it's interesting because on one hand, it's sort of that, oh, so many people have a first trimester loss. You don't have to worry about it. The baby probably wasn't healthy and it's for the best, and you'll go on and have another pregnancy, right? So on one hand, it's sort of like suggesting that it's very common. But on the other hand, we don't know how to talk about it. And it's also not reflected in how we talk about reproduction, right? Like when we're taught in school about pregnancy, we're not taught about loss. Lots of fertility clinics don't have robust, in fact, I think most fertility clinics don't have robust pregnancy loss. They have robust pregnancy loss programs to get people pregnant, but not to support pregnancy losses. So it's still sort of like a bit outside, right? It's not really, it's thought of as like a women's healthcare issue. So I think part of it, again, how we talk about it and how we look at it. And then women end up feeling like this is their fault, that they've done something wrong, either previously, right, earlier activities or habits or choices, or currently that they did something wrong, that it feels like there's something wrong with them. And I think that sort of, interestingly enough, goes back to that idea that we talked about with loss and infertility, that difference where like infertility, that you're not conceiving, but miscarriage is like you can do that, but you can't do this. And that somehow a lot of women internalize that as being about them, that their uterus is about them in a way that maybe once they've conceived, it isn't. And the harm that is done when there is no attention paid to the impact emotionally is so damaging. It ultimately makes women feel, for lack of a better word, crazy. And then whether it's doctors or friends or parents or partners sometimes who aren't experiencing, who aren't embodied in the experience, telling them that it's not a big deal, that they're being dramatic, that they should be over it by now, that it wasn't a baby, that it was for the best, that it was, and now I'm using air quotes, God's will, like all those terrible things that people say, because they don't know how to say, I'm so sorry. This is so terrible that this happened to you. This was not your fault. And I'm so, so sorry for your pain, which actually seems like such a simple thing to say to somebody.
It's interesting you say that, because when I see patients after a miscarriage, obviously go through the medical quote unquote spiel, let's say. And I've now started telling everyone, regardless of whether they ask the question or not, you know, I'm going to tell you this. If there's somebody there with them, I say, you're going to repeat this to them. And I say, this is not your fault. It's not a function of something that you did or that you didn't do. It's not because, and I give examples, you took your progesterone suppository 30 minutes too late or whatever kind of scenario. Sometimes people look at me and they're like, yeah, I know. But I think that it's so important to say that, even if it's not a question that's asked.
Yeah.
And it's something that I have now for sure incorporated into every patient that I see after a miscarriage, and also around infertility discussions as well, just to say that even if people aren't asking the question, because as you mentioned, there is the shame and the anxiety and the fear, and they may be thinking it. I now realize they might be thinking it even if they're not verbalizing it, and that saying it as quote unquote the doctor, the person with, the quote unquote expert, I hope carries some power. It's worth saying for sure.
There's a very, very powerful scene in the movie Good Will Hunting where Robin Williams is saying to Matt Damon, it's not your fault. And I saw that movie a million years ago, and somebody just posted this recently, so I can't even remember the context of the scene, but it is an unbelievably powerful, like 2-minute, 1-minute scene where Robin Williams says to him, it's not your fault. And he says, yeah, I know. And Robin Williams for about a minute just keeps repeating it. He just keeps saying, it's not your fault. And at first, Matt Damon's character is like, yeah, I know. And then he's like, yeah, I know. Yeah, I know. And then he gets kind of upset and mad. And he's like, I know. Like, what are you doing? And Robin Williams keeps repeating it until Matt Damon's character starts bawling. Because I think you could know that it's not your fault. I suspect that most people that you say to them, do you think it's your fault? Most of them will be like, no, I don't think it's my fault, but I do feel like it's my fault. So I think saying that right off the bat is so powerful, telling partners to repeat that and giving space for somebody literally to keep saying it. Like, is this my fault? Could this be my fault? So you can keep saying, this is not your fault.
Yeah. And I think two things could be true. You can, like you mentioned, say, this is terrible and I'm really sorry for your loss, and meet patients where they are at that moment and acknowledge the grief and the loss in the moment. And at the same time, they do have questions. When can I conceive again? Was this a genetic problem? What is next? What are the steps? And I think it doesn't mean that you do one or not the other. You can certainly do both, but it's a question of not eliminating one for the other. It's the art of really meeting people where they are and giving them space and acknowledging that today, right now, there's grief and there's loss. Yes, it was probably a genetic problem. Yes, you potentially can conceive again. Yes, it's very common. Yes, it was not your fault. But one thing doesn't take away from the other.
And that's where I would say a good word to use is the word and instead of but, right? That all of this is true and all of this is true. That if it was a first trimester loss or an embryo that didn't continue to grow, it likely was a chromosomal issue. And that doesn't mean you can't feel pain about it. And there's a good chance you will get pregnant and it will be successful. And you have a right to be afraid about that, right? So that and can be really very, very helpful. I also want to say, because we're, of course, talking about the pain that people feel when embryos don't develop, when they don't attach, when they do attach, and then they stop growing. You said something that was very interesting there about people sort of wanting to move forward. And certainly I would say that while lots of people are quite overcome by the grief that they feel, especially with recurrent loss in some people or other people who have a very early loss and want to keep going, their emotions can also be quite complicated where they feel like, I don't have time to grieve this right now. Like, I don't have the luxury of just sitting at home and crying. I need to figure out next steps because I don't have time to waste. There's also people who their immediate reaction, which they feel great shame about afterwards often, is actually one of not just despair about losing a baby, as I just using that language again, but also a feeling of like, oh my God, I can't believe I have to go back to the clinic. I also want to highlight that while miscarriage, perinatal loss is devastating no matter how you have gotten pregnant, there is something very unique about people who their pregnancies are achieved through assisted fertility, right? If they've had to spend thousands of dollars to buy sperm, to buy eggs, to work with a surrogate, to do IVF, you know, like that it isn't as straightforward physically or financially as going home and trying again in a way that is loving and safe in your bedroom. While it may not feel that way if you've had recurrent losses at home, of course, but it is a very, very different scenario when in order to get pregnant again, it could cost you $30,000 or more.
Mm-hmm.
So that there are definitely people that that's where their brain goes to first, and then they feel a lot of shame about that.
I think at the end of the day, all feelings are valid feelings and they are confusing, and you can feel all the things and then some,
Yes,
the full spectrum. Absolutely. And I think that's what makes humans human.
absolutely. And that idea that you don't have to feel one or the other, right? That isn't that people who think from that practical, logistical way first, it doesn't mean they aren't having an emotional experience. It just means that their brain is trying to protect them from the emotion by thinking about the other thing first.
Oh, yeah. For many people, it's definitely a coping strategy that if they know what the next steps are in their mind, that settles their brain in some way. As someone who's very type A myself, I know that that's one thing that helps me for sure, having the next steps, the plan. So I totally get that, right?
I remember having an experience because, when you're talking about the different experiences of infertility and miscarriage, I'm just reflecting on my own journey. And I had primary infertility, then I had secondary infertility and recurrent miscarriages. And you're right, they're all different. But I remember, to your comment of your brain protecting you, I had a miscarriage, which, to your point, also, it was conceived spontaneously, which was a big deal for me because at this point, I had done lots of IVF. I already had a child, and I did not think, I'm talking maybe 6 years into being married, I did not think this was possible. And then I conceived spontaneously. So I was very happy that I was pregnant, but also that it happened on its own because I felt a little bit like, hey, I'm normal again. And then I had a miscarriage and I needed to have a DNC and I needed to work. I was on call. This is at the time when I was doing deliveries, and I had a 24-hour shift on call delivering babies. And so I had my DNC, and the next day at 8 in the morning, I had to show up. And I was so worried that I was going to burst into tears in the middle of a delivery or in the middle of a patient assessment or anything like that. I did my shift and I actually spoke to the nurse in charge. I said, like, listen, this happened. If you see me doing anything different, just intervene, pull me out of the room, throw water on my face, slap me, like do something, but please don't let me break down. So the nurse in charge was great. And then I went through my shift and I got home and my husband, who was worried, was like, how did it go? I was like, yeah, no, that's great. I did the things, I delivered. I didn't cry. I can't believe that I was like so stoic. And then, of course, I had a little nap because I hadn't slept for 24 hours. And then I woke up. I think I cried for 24 hours straight after that shift. Like I just could not stop. Like it just kept coming. And it shook me, that idea that you can compartmentalize so that you can think that you're okay, only to slap you in the face, later. So can you talk about that? Can you talk about the idea of putting a brave face and doing the things and showing up for the things that you're committed to? And maybe some coping mechanisms for people that have to do that. Yeah.
And how to stop doing that to some degree too.
What you've described takes a very strong amount of internal courage and strength and an ability to compartmentalize for sure. Most of the people I speak to have incredible capacity to do that at different stages. But the truth is that even people who are really good at that aren't always good at it, right? Like you think about lifting weights and there's, people for sure they can lift heavy weights, but that doesn't mean they can hold that heavy weight indefinitely, right? At some point, there is a breaking point for everybody. And so in that scenario, you were able to kind of ward that off for a little bit and then it hit you. And it's a good thing it did because those feelings needed to come out. And so one of the things I always say to people is try not to be afraid of those feelings. They aren't going to destroy you. Does feel like if I let myself feel that, I'll never not stop feeling it. And to some degree, that's true. We don't stop feeling grief. It just, the wave isn't as strong, right? And so being able to really look at what it is that you have to do. Do you actually have to go into work? Can you take a day off, 2 days off, a leave? Can you call in sick? Can you cancel those plans? Like, what is it that it feels like you need to do? And part of that feeling of needing to do it comes from minimizing what you've been. It's not unusual that people say things to me like they don't understand why they're so sad and they're still crying. And I'll say like, this just happened. And they'll say, no, that was 3 weeks ago. I'm like, this just happened. You're still bleeding. This just happened. And so we are very, very quick in our society to close the door on grief, especially when the loss happens within your own body, that it's easier for other people to not think about it anymore because it happened and then it's done for them. But for you, that miscarriage may be 3 months long, right? Of bleeding, of not having a normal cycle, of having to go back for testing. So I think giving space to acknowledge the depths of this grief in all of the ways, physically, practically, financially, emotionally, any particular things around it that make it more complicated. The fact that there was a natural conception, I hear that from people all the time, and it feels especially cruel after infertility to have a natural conception and then have it end that way. For people who, again, have those additional complicating factors of having to use third party and assisted reproduction to get pregnant, giving space to acknowledge that makes it really, really hard. And once you let yourself recognize that, you can then give yourself space to grieve that, which then allows you to stop actively grieving it in a way that makes it that you're crying for 24 hours, right? Because you didn't continue crying for 24 hours, right? So you cry. And then I imagine that within a few days and a few weeks, you started slowly, slowly feeling better. That doesn't mean that even now thinking about it, it doesn't bring up grief, but you're not activated and actively in that grief in the moment.
I think society really glamorizes compartmentalization, and then it's seen as such a good thing as, I think the word you said is stoic. Like, oh, I was so stoic. And we see that as a compliment, right? It self-perpetuates. And I have to say, in my opinion, physicians, we are the biggest compartmentalizers of all time. I would dare to say that our training, our medical training, makes us that way. teaches us how to compartmentalize and tells us that that's what we should be doing. And so that's a whole other avenue about that. But what I wanted to say was ask about partners. Dr. Garcia, you mentioned that you came home and your partner asked how your shift went. And you said, I was proud of myself. I didn't cry for the 24 hours. I made it through. And your partner kind of goes off based on that and is thinking, okay, she did great for 24 hours. Okay, good. She must be doing okay. I imagine that's what he was thinking. And then he sees you just crying for 24 hours. I imagine partners are often going through their own grief experience, which is different. Also extremely valid, but different. So what can partners do to support, let's say, their partner who's experiencing a pregnancy loss or has had a pregnancy loss, while also taking care of themselves? How do you navigate that?
It's a really good question. And I think especially because partners are so rarely asked how they're doing, it's often, in fact, it's very common that I hear that at any stage in a loss, that the question is always like, how is she doing? Without recognizing that, in fact, depending on the circumstances of it, it actually could have been not just emotionally painful, but incredibly traumatic, right? Like there was a lot of bleeding, if an ambulance had to be called, if there was a situation at a hospital where a decision had to be made about whose life was going to be focused on, like that there are all kinds of devastating things where actually a lot of that is actually on the partner because the person experiencing the loss is maybe not conscious at all or in so much pain that they're not aware of what's happening. So there's a lot of trauma on both sides. I think one really good way of supporting a partner is actually paying attention to your own pain. If you are so much compartmentalizing your own pain and trauma, it's going to be really hard to be present for your partner who might need to share how they're feeling. So just because you weren't the one carrying the pregnancy or having the physicality of that loss does not mean that this wasn't devastating and traumatic for you in some way. And so I think paying attention to that, really seeing like, would it be helpful for you to speak to a therapist? Like, do you have anything to work through? And maybe you don't, but maybe you do. And you have to put your own oxygen mask on first to some degree. And I find partners almost never do that in fertility. They're typically always looking out for their partners. I think finding out from your partner, and you might know this, but you might not, is it helpful to talk about your own feelings? Sometimes that feels counterproductive and partners feel like, if I tell her that I'm sad or I'm traumatized, she'll get angry at me or she'll feel abandoned, or then how's that going to help anybody if we're both a disaster? But what happens with the opposite when the partner is like, it's okay, it happened early, the doctor said it was probably chromosomal, it'll work next time. It just increases women feeling crazy. It just increases them feeling like, my partner doesn't care as much as I do. How could they not be impacted by this? I'm alone in this. So getting a gauge, maybe not the day that things are happening, but finding out, like, is it helpful to talk about your feelings? Oftentimes, the person who's undergoing treatment, the person who is pregnant or was pregnant, is saying to their partner, are you okay? How do you feel? What's happening with you? Like, I'm fine. I'm fine. I'm worried about you. I'm fine. So I do think it's really important that you give space for that. When medical things are involved, coming to appointments, like don't leave it to the person who's getting pregnant, trying to get pregnant, to go to appointments alone. That is an additional burden on her. So go to appointments, find out what kind of questions you can ask the questions she may be afraid to ask, right? If she's saying to you at night, I think this is my fault because I had an abortion, because I had an STI, because I went dancing, because I whatever. Say that to the doctor. Say she thinks this is her fault because oftentimes people are really given very little information, right? They're told, take this medication, you'll have some cramping, you'll have some bleeding, and we'll do an ultrasound in a couple of weeks, or, go home from the hospital and it'll be okay. If you're the partner that's there, you can ask, what does that mean? Like, how much blood will there be? Can she go to work? Can she commute to work? Can she take the public transit? Like, should she stay home? How many days should she stay home for? How much pain should she be in? Did she get a pain medication? The role of the partner, both in terms of managing their own emotions and finding space for it, And being an advocate for your partner is incredibly important in this time.
I have a question for you, Dara. We talked about partners, but I want to talk more about your friends or your coworkers. And the reason that I want to talk about it is because, again, just sharing my own experience, I went through my whole fertility journey while being a fertility specialist. So I had clinics booked with patients on the same day that my beta was due, or on the same day. In one particular time, I remember my beta was great, and then it was just a repeat, and I thought it would double. And I had a full clinic. I'm not going to cancel a whole day just because, I'm doing a 2-second blood test that I was doing at the clinic. So I had a full clinic booked. And I remember this is in the time when the patients were in person. And somebody came into my office and just put a piece of paper on my desk. And it was my beta, which was lower than before. And they're like, patients in front of me. The reason I'm asking you is, so my assistant at the time, Kelly, who anybody who works at Market Fertility Center or anybody who is a patient of Market Fertility Center has to know the amazing Kelly DeRosa. She is like the heart of our clinic. And at the time, she was my assistant and she knew everything that was going on with me. She had booked all the patients and she really, really cared about me as a human being, besides the fact that I was her boss. And of course, when these things happen, she would want to come to my office and say, how are you? And are you okay? And what can I do for you? And I hated her for it. We actually needed to have a conversation later on because it was really hard for her how much it shut her off. But at the time, I didn't have the words to explain it. But I was like, it's a door that has to be closed when I'm at the office and seeing patients. I cannot do this, like open and close the door every 5 minutes. I need to shut it, lock it, throw away the key. And then at some other point when it's safe, I need to open the door and go there. But of course, I made it a little hard for her because here's somebody who deeply, deeply cared about me, knowing that I was going through something hard. And she's supposed to just be like, your 10:30 is late, or you have patients until 4, or like, here are the test results you asked for. That's all that I allow her to talk about. And she really wanted to do more. And it was really hard for her. And we had a really healing conversation years later about that. And of course, now sometimes I'm myself in the situation that she was in, wanting to support other people and really feeling the same. Like I did not want anybody to talk to me because I was at work and I needed to concentrate. But yet again, you don't want to be the unsupported friend who is like ignoring what you're going through or not acknowledging. So how do you think people should navigate that dynamics if you are going through it at work and the people around you may know, either because you're close to them or maybe you happen to work at a fertility clinic and you're having to navigate that concept?
I mean, I would say, first of all, believe people when they tell you what they need. It's our responsibility as human beings, as much as we can, to tell people what we need. And as loved ones, whether that you fall into the category of parents, siblings, friends, coworkers who care, it's our responsibility to believe the person. So when somebody says, I can't talk about this at work, to believe them that it's not personal, and to see if there are other ways that you can have those conversations. For example, somebody could write a note and say, just read this at home. Right? And not like, oh, read this at home with like sad face, but just like, hey, read this when you get home. And in it could say, I love you. I want to support you. I know you said you didn't need anything at work, but please know I am here for you. And I would say that it's very easy to say, let me know if there's anything I can do. But it's rare that somebody is going to take you up on that as opposed to offering things, right? So saying to somebody who is a close friend, I know you're working all day and there's still physical things happening. Can I get groceries for you? If it's somebody that you work with, is there anybody that I can bypass for you? Is there anything that's happening at work that's making it more difficult for you? Can I be helpful in these ways? I think finding other ways to check in on people that you love without crossing a boundary that they've set. And I know that that can be hard because you want to help. And if somebody is saying they don't need your help or they don't want it in the way that your instinct is to give it, it can be hard to hold that back. But you want to remember that if a person asks you not to do that, then what they need is for you not to do it. So telling them that one time that you're there in a way that they can hear and then believing their boundary.
I'd like to address another big topic in the pregnancy loss, community pregnancy loss world, and that is pregnancy after pregnancy loss. And this is a generalization when I see a patient who has infertility and they have a positive pregnancy test, or, they do their first beta and they do their second beta, it's rising. Often, and not always, this is a generalization, the emotions are happiness, right? The people are happy. They weren't pregnant. Now they are. They're feeling good. And it's a very different set of emotions, different vibe generally. And again, this is not for everyone. But patients after pregnancy loss who are now pregnant, whether that's recurrent miscarriages, one miscarriage, whatever the scenario is, it's different. And very often, I think that society expects them to be happy because they're pregnant, or that they've gotten past some theoretical boundary, some theoretical time frame where they quote unquote should be happy. And maybe they're not. Can we talk a little bit about those emotions? Because I think pregnancy after pregnancy loss, I think those emotions are harder for people to talk about because it comes with a lot more shame, probably embarrassment, and this thought of, well, people think I should be happy, therefore I'm going to make myself happy. I'm going to present as happy. But yeah, what are your thoughts?
It's such an important thing to talk about because the emotions that come with pregnancy after infertility and after pregnancy loss are so powerful. And not only do people around you expect you to be happy, but often you expect yourself to be happy. Oftentimes I find people are really surprised at how their anxiety spikes, at how they're not happy. And other times they know it, right? Somebody who's had 4 miscarriages is not expecting to be happy when she gets pregnant again. And oftentimes when people say to me, I feel like I should be excited, I feel like I should be happy. And honestly, I say to them, why? Like, why do you think that that's how you should feel? I mean, if every time you came home, you opened the door and somebody punched you in the face, would you be excited about coming home? It is completely understandable that you're not excited and happy because your history is telling you that this pregnancy is not something to celebrate. It's actually something that is going to bring you increased pain, physical and emotional. So I think the first thing is for people themselves to work at that, at recognizing that you aren't obligated to feel any particular thing. It's wonderful and lovely if you're able to feel happy and excited. And it's also okay if you're not. And for the people who are in the loved ones category, to really think carefully about what you're saying and what you're putting on somebody else. Interestingly enough, I don't know how to say it I think it's, I don't know if it's in Hebrew or Yiddish, but there's what you're supposed to say when somebody is pregnant. And we think of it as mazel tov, which means congratulations. But actually, you're not supposed to wish that to a woman who's pregnant, because that is making an assumption that actually there is something to be congratulating her for. So actually the saying is more along the lines of, may God protect you, like may everything be good. And I think a lot of cultures and a lot of religions have that sort of superstition in it. And so for some people, not being excited might be sort of a cultural norm, even if actually the pregnancy wasn't difficult to achieve. And for other people, there isn't. There's just this like, oh no, it's going to work this time. Like it's for sure going to work this time. You don't have to worry. You can't think negatively. You have to think positive. And so what I often tell people is, you're not a wizard. What you think is not making a difference here. So if actually some days you're feeling super negative and you're convinced it's not going to go well, that's not doing anything except for extending your suffering, right? It is making it harder for you to feel those things potentially. But it's also okay. One of the strategies I talk to people about is the brick strategy, where somebody who has gone through, let's say, recurrent loss, because that's what today's topic is about, that when they first started trying, likely they had a fairly open heart. They were super excited to start trying. They got pregnant. They were so happy. And then it ended when it ended. They were devastated. And then they got pregnant again, and they were a little more hesitant, but everybody told them that it was a first trimester loss and they didn't have to worry. So they were still hopeful. But by the time they get to their 4th or 5th loss, their heart is completely sealed up. And that goes true with people who've had later pregnancy losses. So somebody who their first pregnancy ends at 25 weeks, getting pregnant again, or even the idea of getting pregnant again, knowing how scared they're going to be until they're past viability is very terrifying. And so what I talk to people about is imagining all the things that led up to you being this scared as bricks that you've placed around your heart to protect yourself. And it's actually admirable that you've done that, right? Not being excited is how you're trying to protect yourself. It's totally appropriate. The problem is if you still feel that way when your baby is born, if you still feel that way when they're 4 and 5 and 20, the truth is that bad things can happen at any time. Bad things can happen during pregnancy to fetuses, and bad things can happen to infants and children and teenagers and people's 50-year-old children. And so if you don't want to be sitting on the edge and you don't want to be worried and anxious all of the time, you have to backtrack that at some point, right? If you want to have an open heart when your baby is born and you want to be able to lean into the baby and believe that they're here and believe that you're a parent, that has to start at some point. So what I challenge people to do is to think, at what stages can you start taking down some of the bricks? Not all of them, because those bricks are there for a good reason. So when you get a positive pregnancy test, can you take down half a brick? And some people are like, no, definitely not. I'm like, okay, brick stays. Second pregnancy test, heartbeat, 9-week ultrasound. And when people start thinking about that, they think, okay, I think at that point I can take down 1. I think at that point I can take down 3 bricks. So really thinking about it in a concrete way, and you can link that to some kind of acknowledgement, right? So when you get a positive pregnancy test, are you going to allow yourself to smile? Are you going to allow yourself to hug your partner? When there's a heartbeat, would you allow yourselves to go out for a celebratory hot chocolate or muffin, right? Will you allow yourself to tell somebody at this point? Will you let somebody say something nice to you? And that way people are able to feel like they're still protecting themselves. That brick wall is there for a reason, but that they're actively working to allow some of that joy in, so they don't get to a point where the baby's here and it just feels completely like they're still numb, which is not what anybody wants, of course. But it is an active job to be able to do that, because pregnancy after loss is terrifying.
And also the notion that if you are sad, you will protect yourself from the loss. It's not really true, right? Because you can't say, I'm just going to be X% sad so that when the bad thing happens, hey, I don't have to be sad again because I'm already sad. Like, it doesn't work like that, right? You still get the grief and the devastation and the loss and the sadness that you had leading up to it. Doesn't actually protect you from the sadness going forward. But yes, I understand your analogy. It's perfect. Like, if you get punched in the face every time you enter a room, you're like crying to know that. And the idea that you're trying to protect yourself, that's what people say. I just don't want to be too excited just in case. But the truth is that if the just in case becomes real, the grief is coming.
Yeah. And I definitely talk to people about that as well. There could be a point early on where not getting excited can protect you a little bit. But for sure, there's a point in pregnancy where that's just not possible.
That's
Like,
right.
it's just not possible. It doesn't matter how many times you tell yourself that. If you have a loss, it's going to be devastating. You can't protect yourself. And part of the reason you can't protect yourself is because it doesn't matter how many times you tell yourself not to get excited or how many times you tell yourself you're probably going to have another miscarriage. You actually don't believe it. Because if you believed it, you actually wouldn't be getting pregnant. You would be using an egg donor or an embryo donor or a surrogate or adopting, or you would stop. If you truly believed that it could not work, that you will never be able to do this, you would never put yourself in that position. So part of you really does believe it. We are astonishing human beings, right? Human beings are astonishing in our ability to hope. And that hope is there whether you let yourself feel it or not. So the idea of saying, okay, I am going to allow myself to have some hope, but I'm going to control that. Like, I am going to give myself an opportunity to let some of that joy in, to start moving towards that in a way that still feels safe, because I'm still going to allow myself to have some of those protections. And I think that helps people feel a little bit more in control of it, and also allows them to recognize that there are some good things here. And that's something else that I tell people to do, is to stay as present focused as you can. Because when somebody says to me, you know, people keep telling me, congratulations, that it's a positive pregnancy test, but there's nothing to celebrate. And I say, like, there's only nothing to celebrate if you have a miscarriage. If you don't have a miscarriage, there is something to celebrate. So our job at each of these stages is to stay exactly where you are. So when you get a positive beta, should you be celebrating a second positive beta? No. Should you be celebrating a baby? No, it's not a baby yet. But can you recognize that you are never going to have a baby if you don't have a first positive beta? There has to be a first positive beta to get a baby.
Right.
Right? Each stage, pulling yourself back, because the anxiety isn't coming from the news today. The anxiety is coming from what you think is coming towards you from the future to you now. So if you could say to yourself, is this by itself, like imagine you're looking in a box, is this news on its own good or bad? Not how happy or excited I should be, but just, is it good or bad that there's a positive pregnancy test? And somebody will say, well, it's not good if tomorrow. No, not tomorrow, today. Is this good or bad today? For a lot of people, it is a constant effort to take a breath and bring ourselves back to, what is the news we got today? And that's how you try and get through it, right? One day at a time with the news that you have in front of you.
Again, it's been another incredible conversation with you today, Dara. Thank you for your words of wisdom. And I have to say that brick analogy, the brick wall analogy, I'm borrowing that. I love that. It's also really helpful for myself as a fertility physician, because you're seeing these patients in clinic who are experiencing these recurrent miscarriages. And I'm trying to figure out what emotion I'm supposed to portray. And I sometimes wonder if the patient is trying to figure out what emotion I'm trying to portray, to figure out what emotion they should be feeling. Like, it becomes a little bit of this kind of weird emotional standoff almost, if everyone's trying to figure out how we're supposed to feel. And so I've actually started just saying it and addressing it and just saying, what are our emotions? What are we feeling today?
Fantastic.
To close off here, if there is somebody who has tuned into this podcast because they have just been told that they have a miscarriage, or they've just experienced a miscarriage, what advice, what do you want to tell them? What do you want that person to hear?
I'm going to say a couple of things. One, I think it's fantastic that you are asking people, that you're sort of naming that elephant in the room. And I think that that's really good advice generally, to be able to just, it goes back to that idea of believing people, being able to say to a patient, like, I'm feeling really hopeful about this, but you tell me how you want me to talk to you about this, right? Lots of people find it helpful when, if somebody says to you, I'm going to hold on to hope for you, it's okay that you're not feeling hopeful. I'll hold that for you, and you feel however you feel. So I think as physicians, being able to say to people, things are looking really great and I'm feeling hopeful. I understand though if you aren't. So I think your approach is really fantastic. I think for people who are going through this, to really try and give yourself space to understand how you want to talk about it and how you want other people to talk about it. For example, if you've decided that you're going to tell somebody that you're pregnant, and your worry is that they're going to get all excited and you don't want them to, then that can be part of how you say it, right? Saying to somebody, I do have an update for you. And I'm telling you right now, what I want you to say when I tell you is, thank you for telling me. I love you. That's it. I don't want you to say anything else. Can you promise to do that? Then here is my news. That really being able to think through, okay, what is it that you need from people? And sometimes you don't know. And unfortunately, sometimes you don't know until somebody tells you or gives you the exact thing that you don't want. What I will say is that, and it sounds cliche, but trying to stay as much as you can in the present day. Anxiety does not come from today. It never does. Anxiety comes from yesterday and tomorrow. And so asking yourself that question, is it good news or is it bad news for today? Sometimes, with not all clients, and certainly not right after they've had a loss, but sometimes one of the things that I will jokingly say to people is, if I asked you how your marriage was, you wouldn't say it's okay so far. Now, we don't know what's going to happen 20 years from now. Maybe your marriage will fall apart, but you're assuming it won't. And you're assuming it won't based on your history with this person, not based on the future, because you don't know. So when you're pregnant now, Your fears are not coming from this particular pregnancy unless they are, right? Like maybe there is something happening with this pregnancy that's giving you reason to fear, and that's very valid. But if you're looking at this pregnancy and your doctor is telling you that everything is meeting parameters and you're thinking, okay, but that's what they told me last time. This is a totally different embryo. Your uterine lining is totally new. It was different egg, different sperm. And so that comes back to that, what do I know is true today? What I know is true today is that I had a good first beta, I had a good second beta, I had a heartbeat. My doctor says everything is going well. That is what I know today. And so taking those deep breaths, bringing yourself back to today is incredibly important, because going into tomorrow it's increasing your pain when there doesn't need to be that, right? You don't know what's going to happen in that way. And obviously there's many, many, many strategies, of course, but I would say that brick wall one, helping to focus on today, staying present focused, asking yourself, what do I know is true? And that's a great thing for a partner or a friend to say. If you're sort of spinning out, for your partner to say, okay, what do we know? What do we know about this pregnancy right now? What do we know to be true today? And as much as you can, bringing yourself back to today. I know last time I did with a quote, and there was a quote I wanted to share. I have it here. It was actually shared with me by a client of mine who's had recurrent pregnancy losses. She's had many, many pregnancy losses. And she sent me this, and it's so beautiful. I actually don't know if I'll be able to read it out without crying, but I'm going to try because it's really beautiful. And it goes back to this idea of grief and loss, and people saying like, when will I get over this? How long will I cry for? Or being afraid to let themselves cry because they think they won't stop crying, or feeling somehow that their grief is inappropriate, that they don't have a right to feel as sad because it wasn't a stillbirth, or because it was, air quotes, just their first loss. All of the reasons we have for minimizing our own grief. So I found this to be very powerful. It's written by somebody named Donna Ashworth. You don't move on after loss, but you must move with. You must shake hands with grief, welcome her in, for she lives with you now. Pull her a chair at the table and offer her comfort. She is not the monster you first thought her to be. She is love. And she will walk with you now, stay with you now peacefully if you let her. And on the days when your anger is high, remember why she came. Remember who she represents. Remember. Grief came to you, my friend, because love came first. Love came first.
Wow. That is incredible. And you made me cry.
I know, I can't believe
I never tear up though.
Yeah.
Ask her.
That's true. She's right.
And that's actually what we say all the time, is that grief is love with nowhere to go. And so being able to recognize that that was your baby. It doesn't matter if it was an embryo. It doesn't matter if it was a 1-week attachment. If you thought that that was going to be your baby, it's okay to think of it as your baby. And thinking about it that way, for some people, isn't helpful, and I respect that. But for some people, it is helpful, because that's the difference, really, when we think about a later term loss and an early term loss, is that a later term loss, you can name that baby. People saw you pregnant. Religions and cultures have rituals for burial, for grieving. We don't have any of that for early losses. So that's why they're, back to what we started off today, that's why they're invisible losses, because there's nothing, there's no body, there's no prayer, there's no ritual, like nobody knows what to do. It's not for everybody to think of it as a baby, and I do want to respect that. But if you can, it does give somewhere for that grief to go. It allows you to recognize that you had love for what you thought was going to be your baby. And that gives you space to mourn in a way that feels real to you. And that validates the feelings that you already have inside of you.
That's amazing. Thank you so much, Dara. As usual, you do not disappoint with your wisdom and your depth of knowledge and your ability to make me cry. Thank you, friend.
If you ever have me back, we're all just going to have to wear waterproof masks.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast, or visit us online at myfertility.com. And don't forget, follow, subscribe, and share your favorite episodes.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this. If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music, Island Memories, instrumental by Descript stock music. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.